Hi, I'm Dr. Hudson Nakamura. I am the retina specialist ophthalmologist from Brazil. Thank you very much for participating with us in another Retinawesome event. We learn a lot with each other in different countries with different techniques, different retina surgeries, and the ways we do. And hope you discuss the cases with us and participate. It's awesome to be with you. Thank you very much.
Grande manche, belle douche, la fille d'Ipanema s'est couchée sur les rivages et tout, la plage est faite. Ah, elle est marchée comme une algue, portée sur l'aile d'une vague, jusqu'au rivage et toute la plage est faite. Les garçons la regardaient, et leurs idées qui bavardaient ont des chansons qui s'attardaient sur les corps de les filles aux yeux clairs, mais elle les voit que la mer, grande et manche, belle et douce, comme une voile dans sa course. Il ne voit qu'elle, mais il ne voit que la mer, ne voit que la mer. Moça do corpo dourado, do sol de Ipanema, o seu balançado é mais que um poema, é a coisa mais linda que eu já vi passar. Ah, porque tudo é tão triste. Ah, porque estou tão sozinho. A beleza que existe, a beleza que não é só minha e também passa sozinha. Ah, se ela soubesse que quando ela passa, o mundo inteirinho se enche de graça e fica mais lindo por causa do amor. Por causa do amor. Por causa do amor. When I find myself in times of trouble, the Mother Mary comes to me, speaking words of wisdom, let it be. And in my hour of darkness, she's standing right in front of me, speaking words words of wisdom, let it be. Ooh, let it be. Let it be, ooh, let it be, ooh, let it be. Whisper words of wisdom, let it be. When all the broken-hearted people living in the world agree, there will be an answer, let it be. But though they may be parted, there is still a chance that they will see, and there will be an answer, let it be. Ooh, let it be. Let it be. Ooh, let it be. Ooh, let it be. There will be an answer, let it be. And when the night is clouded, there is still a light that shine on me and shine into tomorrow, let it be. I wake up to the sound of music, and Mother Mary comes to me, speaking words of wisdom, let it be. Ooh, let it be. Let it be. Let it be. Ooh, let it be. Speaking words of wisdom, let it be. Good morning again, ladies and gentlemen, doctors. It's a big honor to me to make part of this beautiful event, and I bring some Brazilian and world musics to you. And now I will play a music from João Gilberto. Cantinho, violão, esse amor, uma canção pra fazer feliz a quem se ama. Muita calma pra pensar e ter tempo pra sonhar. Da janela vejo o corcovado redentor. Que lindo, quero a vida sempre assim, com você perto de mim, até o apagar da velha chama. E eu que era triste, descrente desse mundo, ao encontrar você, eu conheci o que é felicidade, meu amor. Quero a vida sempre assim, com você perto de mim, até o apagar velha chama. E eu que era triste, descrente desse mundo, ao encontrar você, eu conheci o que é felicidade, o que é felicidade, o que é felicidade, meu amor. Marco se n'è andato e non ritorna più. Il treno degli 7:30 senza lui, il cuore di metallo senza l'anima, nel freddo del mattino grigio di città, a scuola il banco è vuoto, Marco è dentro me. Dolce sul respiro e fra pensieri miei, distanze enormi sembrano dividerci, ma il cuore batte forte dentro me. Chissà se tu mi penserai, se con i tuoi non parli mai, se ti nascondi come me, sfuggi gli sguardi, te ne stai rinchiuso in camera e non vuoi mangiare, stringi forte a te, cucino e piangi, non lo sai quanto altro male ti farà la solitudine. La solitudine. Marco nel mio diario una fotografia, hai gli occhi di bambino un poco timido, la stringo forte al cuore e sento che ci sei, fra i competiti inglesi e matematica, tuo padre il suo consiglio, che monotonia, lui con il suo lavoro ti ha portato via, di certo il tuo parere non ha chiesto mai, ha detto un giorno tu mi capirai, si sa se tu mi penserai, se con l'amici parlerai, per non soffrire più per me, ma non è facile, lo sai, a scuola non ne posso più, i pomeriggi senza te, studiare è inutile, tutte le idee si affollano su te, non è possibile dividere la vita di noi due, ti prego aspettami, amore mio, ma illuderti non so, la solitudine tra noi, questo silenzio dentro me, l'inquietudine di vivere la vita senza te, ti prego aspettami perché non posso stare senza te, non è possibile dividere la vita di noi due, non è possibile dividere la storia di noi due, la solitudine. Ora una canzone de Latinoamerica. Dos gardenias para ti, con ella quiero decir te quiero. te adoro, mi vida. Ponle toda tu atención, que serán tu corazón el mío. Dos gardenias para ti, que tendrán todo el calor de un beso, de esos besos que te di y que jamás encontrarán en el calor de otro querer. Y en tus brazos vivirán y se hablarán cuando estás conmigo. Y hasta creerán que te dirán te quiero. Pero si un atardecer las gardenias de mi amor se mueren, es porque he adivinado que tu amor me ha traicionado, porque existe otro querer.
The wrong, I opened the wrong camera. Sorry. I mean the audio. And thank you, Gabriel, for the great musics. And you know, it's an honor always to be here with you guys. And we had, you know, three very important people in the field of ophthalmology, especially in retina, that passed away recently. Dr. I will ask Guilherme to put the slides. Please, Guilherme. Roberto Abdallah, he died last week, and he was a great retina surgeon, and he operated a very important soccer player, Tostão, here in Brazil. Tostão participated in two World Cups, and if it was not for Dr. Roberto Abdallah, he wouldn't be able to participate. And Tostão, then he became a doctor, and also he writes for the very known paper here in Brazil, Folha de São Paulo. And also another doctor from our city here in Goiânia, Brazil, Dr. Eduardo Jorge. He died 4 days ago as well. Pode pôr o próximo, next, próximo. So Eduardo Jorge from Goiânia. O Eduardo Jorge, a próxima slide. He also died. And also Dr. Não está indo o slide? And also Dr. Jorge Mitri from São Paulo as well. And it was bad, but at the same time, we know that they were so important, and their legacy is going to keep on going in our thoughts in the field of retina and vitreoretinal surgery and in medicine as well. Just a moment. Oh yeah, now we have here Dr. Eduardo Jorge. Dr. Eduardo Jorge passed away 4 days ago. He's from our city here in Goiânia. And also Dr. Jorge Mitri. Dr. Jorge Mitri, pode pôr o próximo, Jorge Mitri. He participated in many Retinawesome meetings here. And so I would like to ask, with music from Gabriel for 1 minute silence. Thank you, Gabriel, for contributing to this so important moment for us, for the world of ophthalmology. Thank you very much. And if you want to play the music for this moment, Gabriel, Thank you. We'll be happy. Okay, thank you very much.
As a tree of green, red roses too, I see them bloom for me and you, and I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed day, the dawn, sacred night, when I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people going by, and I see friends shaking hands, saying, how do you do? They are really saying, I love you. I heard babies cry and I watched them grow. They'll learn much more that I never know, when I think to myself, what a wonderful world. And I think to myself, what a wonderful world.
Thanks a lot, Gabriel. Thank you very much. And we are happy that we can count on those friends forever. They, as I said, they just left us with a great legacy from the world of ophthalmology and retina in vitreous. And I wanna, because we are admitting here Emmanouil, we have Athanasios, we have Natarajan. Ahmed, how are you? Everything all right? Hi, Natarajan.
Hi, Hudson. Very sorry to hear about our friend George Mitra. He's a very old friend.
Yes. And
How old was he? How old was he?
I'm not quite so sure, but 60 something, I'm not sure, but he was still young. He was young to you die so early. And, you know, but it's good that we have him in our hearts, and it was great to participate with him here in all events, and also all their local events as well. And as a friend, and many times. Thank you. And welcome first time, Ahmed Salam. And thank you very much for participating with us in the Retinawesome. This program is being recorded and it will be in YouTube later on this day. And it's always an honor to have known you in Saudi Arabia. It was great. And we loved your lectures. And I'm pretty sure you're gonna share it well. Thank you. Welcome for Retinawesome once again. Your mic is muted, Ahmed.
Sorry, I apologize. Yes. Thank you so much, Hudson. It's a pleasure and honor to be here. And thank you for the kind invitation.
Honor is all ours. And Emmanouil just got in. And Athanasios, how are you?
Well, I mean, first of all, I'm very sorry for the losses. It's from athleticism, it's from anybody, basically from our friend. It's a bad day, but we should carry on. And I'm in the middle of a Greek meeting, which is happening in a city here. And I'm in the lobby of the hotel, which is a lot of noise around me and everything. But this is the only spot I can get a Wi-Fi that I can project. So you have to excuse me because sounds are coming from everywhere. And I'm in the middle, and that's the best I can do. And about half an hour from now, I have a lecture to give in the other auditorium. So it's getting a little bit mixed up, but I don't take most of your time. I want to salute all my friends, and especially Nataraja, to know if you get the tickets to come to Greece, because he usually says so then he sells the tickets and he doesn't come. And if you allow me to present my short video and go to the auditorium.
Yeah, sure, why not? And you're going to present first, so we warm up and start the Retinawesome program. And then after your presentation, we'll have our friend Emmanouil Mavrikakis from Greece. And Greece is, we are so happy to have Greece as with your presentation, and also for Emmanouil special presentation on ocular trauma as well. And sure, you can go ahead since you have the meeting, Athanasios.
You know, we are very proud. We are very proud in Greece about Mavrikakis. He is one of the leaders now and a strong leader in our society. So I will try to stick after my speech to hear him giving his talk, but after a while I have to go back. So if you'll excuse me.
Sure.
My presentation is just a case where I would share the screen now.
Thanasis, I just want to say hello to Wilson Wong. I think he's from Malaysia. Dr. Hudson, do you know him? Wilson Wong worked in Malaysia with me. Now, Wilson, can you?
Welcome. Yeah.
Wilson, can you hear us? Hi, Wilson. Where are you? You're muted. You're muted, Wilson.
Hi, Prof. Hi, everyone else. I'm in Malaysia.
Okay.
I hope to see you in Greece soon.
Yes, Thanasis is the leader, and we are all going to be with him next week. Sorry, 4th July. Okay.
Looking forward to that. Take care.
Thanasis, a lot of my people who work with me are coming to Greece. I don't know whether they're going to see you or me.
They follow you. These are followers of Natarajan.
Go ahead.
Just one technical question. Did I share the screen or not? Can you see my?
No, we are not able to see your screen.
Not yet. Let me just make you the co-host. You are co-host now. Now you can go ahead. And I'll make the speakers co-hosts as well. So you are ready to share.
Okay, I did. Host. And now I have this short video. I would like can you see now my PowerPoint?
No, Thanasis, we are not able to see.
Not
That's
yet.
always a little bit of a problem here, always with me. I'm getting technically disabled all the time. Let's go back again. I'm going to put it down. Now I'll try to share screen again.
Now.
Okay. So
Yeah, now it's okay. Just
now it's okay.
you see your screen.
And I'm uploading the video. It's okay now?
Sure.
So this is a short video about a young guy who had a motorcycle accident, and he was in bed for 6 months, and he has a big contusion and he couldn't wake up. But after 6 months, he was able to wake up, but he found out that he can't see from his right eye. And we looked at his right eye and found he had a retinal detachment. But it was a very funny, long-standing retinal detachment. And that's what I'm showing you. It was a very long-standing one, and you'd expect to see something different than what I saw. And this is, as you can see, a flat retinal detachment. You expect to have a PVR, but it was full of subretinal strands. The shock was huge. It was a blunt trauma, actually, no rupture of the globe, no nothing. And then we located a few tears around the area by cryo, as you can see here clearly. You can see small, tiny here. But how can a detachment of so many months to look like it's a yesterday's detachment full of subretinal strands? This is a curious subject I have to discuss with you, because if you see an eye like that, so we decided, because of a lot of subretinal strands, to put a 360 3mm sponge as a buckle with a light pipe there in order to release a little bit of the traction on the back. But we still see a very flat retina and immobile, flat and immobile. There's no mobility at all. We clear the traction from the tears, and then we try to remove the vitreous, and that was a shock. While removing the vitreous, we found out that after so many months, it was attached on the surface of the retina. And the vitreous was the one that was holding the retina flat and immobile. So imagine, after such a trauma, after such a damage, to have an immobile retina because of the vitreous attachment. The young vitreous must be something different. And then we had to make, under a retinotomy with 27 gauge, because buckle was not enough to remove the strands. And we tried to use under air, we tried to use the full vitrectomy and then get it with a forceps, 27 gauge forceps, being as less traumatic as possible, and remove one by one these huge little strands that it was behind his eye. You see how tough they are and how they were keeping the retina down. And of course, at the end, it was a little bit simple after laser and silicone oil to put the retina back. But that was the point of my presentation, to show you that blunt retina detachments in young people have a very different approach, and the vitreous is not taken into account as much as we wanted to. The curious thing is that the whole proliferation was not in front of the retina, proliferation was at the back of the retina. And I don't know what the buccal can do to that, but I did use it. So I'm expecting any questions if you have. And thank you very much for the hospitality, Dr. Manusakis and Professor Houston, for what you said. Any questions, I'm open to hear them.
Great case. I would let Natarajan would like to comment on Athanasios' great case. And you know, young and older retinal detachments, they behave differently. What do you think, Athanasios? I mean, Natarajan or any other would like to comment on his case?
I think, as usual, he demonstrated a good vitrectomy and a buckle, and the importance of buckle. And I think a blunt injury producing severe trauma as well as in producing detachment. Wonderful things.
What about you, Ashraya?
Good evening, everybody. Great case, sir. In younger patients, what we have to take care is, I think Dr. Natarajan also spoken extensively about it, but the cortical vitreous, which is very, very crucial to be removed from the vitreous, from the retinal surface, because that is what can lead to recurrent detachments. So use of appropriate staining with triamcinolone to visualize cortical vitreous and absolutely removing it as much as possible can give very good success in the long run. So that is what I think Natarajan sir also has taught us, and we keep following and keep removing all the cortical vitreous in all our cases.
Well, if you don't have any other, I would like to congratulate my friend Mavrikakis, and I talked to him a little bit to understanding Greek. Είμαι στο συνέδριο της Καβάλας αυτή τη στιγμή και μιλάω σε 10 λεπτά. Συγχαρητήρια πάντως. So you learned a little bit of Greek language now between the two Greek people you had, and I'm looking forward for the next meeting in Hudson. Can I be relieved and go back to the meeting? Yeah, okay.
Thanas, see you on 5th July.
4th of July, it's just a celebration for the Greeks also. So waiting for everybody there. Bye, Hudson. And remember, Hudson, we're planning to make a connection with Retinawesome during TVRS. So get ready for Retinawesome and TVRS. Okay. Because we will have YC Lam, we have Nataraja, we have Mavrikakis. So we are just a bunch of Retinawesome in the TVRS live. So we can make a connection with you and promote that, okay?
All right, we are gonna send you the video pretty soon. It'll be an honor.
Okay, thank you very much for the invitation.
Have a good meeting, and
thank you very much.
I'd like to call now Emmanouil, how are you? Could you speak some Greek with us? I'm learning. I started learning something with Athanasios presentially in Saudi Arabia, but I still have lots to learn. You know, it's not easy at all. Are you around?
Hi, Hudson. Great to see you again. Thank you for the invite. Thank you.
So it's an honor to have you again, Emmanouil. You've participated in so many retinosomes, and you've got so much experience and traveling around the world. And last week I was in São Paulo, Brazil, in our BRAVS, Brazil Vitreoretinal Society meeting, and people said very good things about you, Athanasios, and Greece in the retina field. And I'm sure that after doing this retinal fellowship that we did together with Saad Wahib, with Dr. Lam, in Toronto, you've got much more experience, but you are already good. I know you stay on call for city call many times for Greece, and you are probably very busy over there. And if you want to say some words and start your presentation, we are ready to listen to it. Thank you, Emmanouil, once again.
Hudson, The honor is absolutely mine. I would like to deeply thank you for allowing me to be the keynote speaker on this Retinawesome 16 Top Gun. Retinawesome, it was and it is an excellent your idea, and it is a fantastic teaching opportunity, not only teaching opportunity, but a way that during the COVID era, we had the ability to meet even virtually with colleagues and, you know, exchange ideas, exchange surgical experiences, something that it wasn't possible during this time. But even though now that, you know, the COVID era is starting wearing off, again, I think Retinawesome should continue for the experienced surgeons, but as well as for the young colleagues, as it gives the
Καλύτερα, αλλά πρέπει να
opportunity.
έκανα ένα meeting, όπως βλέπεις, συμμετέχω διαδικτυακό με τη Βραζιλία και το μόνο μέρος που πιάνει το ίντερνετ είναι εδώ. Έχω αποκλειστεί εδώ πέρα λίγο. Ναι. Άρα μπορώ να...
If you make me a co-host so I can mute Thanasis, would be great. Because he has left his microphone on and we have some interference. Thanks. Thank you. So as I was saying, this great idea of yours should continue, and we should carry on with more and more Retinawesome. So thank you again for this great honor to have me today as the keynote speaker. I will share my screen.
Yeah, we see your
And
screen.
just let me know that everything is working.
Yeah, we see your screen. It's pretty good.
Great. Thank you so much. So I thought that it would be of interest to give me some minutes to take you through some pearls while we come as an ophthalmologist with the first contact management of a patient with ocular trauma. And then I will take you through some cases with patients with specifically intraocular foreign bodies. And finally, I will end my talk with a recent surgical approach of a 20 years old gentleman with an intraocular foreign body that I had to manage a couple of weeks ago. So I will start with those pearls. As everybody knows, I am the ophthalmologist in chief and director and a vitreoretinal surgeon at the ophthalmology department in the most busiest hospital in Athens, the Emmanouil Hospital. I have no financial disclosures. And the first pearl into managing a patient with ocular trauma is to very carefully listen to the patient. We need to listen to the patient because we need to understand the way that the trauma occurred, and we need not only to understand how it occurred, but we need to very, very carefully document every single detail, because it is most likely that the patient will ask for a later medical evaluation of what happened, or there might be a medical legal involvement. So we need, even in many years later, to remember exactly what and how it happened. And even, you know, police involvement, lower involvement, and everything has to be very, very well documented. So we need to try and find out each and every detail about exact cause and the circumstances leading to this ocular trauma, if it was work-related, and were the potential fragments. Was it an explosion? Were there a broken glass or a metal on metal contact? All these are very important. Also, we need to, to take some history about allergies, about, basic medical history, past medical history, and ocular history related to previous surgeries or any, family history of ocular problems, and of course the timing when this happened, how long has passed, and of course, because we might need to operate on this trauma when the patient had last meal, and to make sure that he is on nil by mouth status, because in most, not in most, or even in all cases, we have to do those repairs under general anesthesia, that the patient has to be in nil by mouth status. So the pearl number 2 is to assess the patient as a whole, and why. We need to make sure that the patient is stable hemodynamically, because there might be an ocular trauma, but there might be some more serious trauma, some head trauma that may need a neurosurgical involvement, or any other extremities, for example, trauma. That's why we need to quickly assess from head to toe the patient, and to decide what needs urgent attention. Because, for example, if there is a head trauma, this needs to prioritize in comparison to the ocular trauma, because it might, have a negative result to the patient's life, while the ocular trauma is not life-threatening. So always assess the patient as a whole human being. The pearl number 3 is we need to be gentle while examining the eye. We don't need to aggravate the trauma, because if the globe is open, then we might make the expulsion of the contents even worse. Avoid placing any undue pressure on the eyeball while examining, and use some topical anesthetic for comfort. Pearl number 4 is assess the visual acuity and the pupil. So, and why is this vitally important? Because visual acuity is one of the best predictors of the visual outcome. The worse is the visual acuity initially, most likely the vision will remain, not always, but most of the time, it will be, the visual prognosis will be limited. While if the visual acuity is good, then the outcome may be better. Note the size and the shape of the pupil. Check always for a relatively afferent to pupil defect. And if there is a badly injured eye, always check for a reverse RAPD. Pearl number 5. Okay, I know we are all in the panel, we are all vitreoretinal surgeons and want to jump into the vitreous, but we need to assess the adnexal structures, make sure that there are or there are not any lid lacerations. Look the canthi, the positions of the punctum and the lid margin, and always take photos. Pearl number 6, visualize the globe. And I know, we all know that it can be difficult to visualize the globe if there is a preseptal edema and chemosis, but we can try and gently, by using a cotton tip applicator, gently lift the eyelid. And if we don't, then okay, we need to do this in the operating room. Pearl number 7, one of the most important pearls: be very careful while you are examining on the slit lamp. The slit lamp examination is crucial. Look for signs of infection, any hypopion, any corneal infiltrates, any reaction in the anterior chamber. Check the size and the depth of any laceration. The AC depth is crucial. Check for saddle sign, negative or positive, with or without pressure. Check for any vitreous, any blood clots, or any lens material in the anterior chamber, any iris involvement, the status of the lens, the clarity and the stability of the lens, as well any traumatic cataract, any swollen material in the AC, or any foreign body on the lens. And always, I mean, if you don't take anything from this lecture, please take this, that don't forget to examine the other eye. Is vitally important to document that the other eye is in a good state. Pearl number 8, prepare your pre-operative checklist, perform basic blood tests and ECG, start intravenous antibiotics, and make sure that the patient has a tetanus toxoid. And as I will describe in a few slides later, in the current era of imaging, multimodal imaging is very important, and I will explain this in a moment. So make sure that you order an X-ray to an AP view and a lateral view, and do a CT scan of the globe and the orbit. You might not take so many important clues, but whatever clue is important to build up your plan, and you need to have a plan before you approach the case. Okay, I mean, they don't cost much, and my idea is you need to do as much multimodal imaging as possible. Avoid any topical medications because the globe might be open and they may cause toxicity. And don't do any MRI, because if there is any metallic intraocular foreign body, then this will be a disaster. Pearl number 9, prepare for the operating room to do the repair or the investigation under general anesthetic. If in doubt about the ruptured globe, better to explore it in the operating room. Prepare for a general anesthetic, and it's better to go and do that sooner rather than later. Confirm, as I said previously, the nil by mouth status, and always, but always, take a guarded prognosis consent by the patient and the relatives. And the last pearl, number 10, is please talk to the patient and the relatives. Explain to them that yes, it was a bad luck, but it has happened. That you're gonna do the best you can, but the eye might be severely damaged, and there might be a poor visual prognosis. And you understand that yes, it's a shocking event for the patient's life, but you will be there and try to do your best, and give your best to the family and the patient. If you allow me, Hudson, I will move on to presenting 3 cases without videos, just the cases and the imaging of those of ocular trauma. And finally, I will finish my talk with the video. So case number 1, this is a 40-year-old male that was hit in his right eye with a high-velocity metallic foreign body while walking in an elevator shaft, a young guy, and was referred for further management after primary wound closure in another hospital. So this is what I'm talking about now, examination and photographs. his best visual acuity was 6.9, almost 20/20 in the right eye. And I mean, that's why we need to be careful. You know, you see here, there is a tiny that can be missed by anyone, as it was missed by the surgeon who repaired the primary repair, and he was referring it for a retinal detachment that it wasn't present. So you have a small, tiny iris defect, transillumination defect. That means that something has gone through the limbus, through the iris, through the periphery of the lens, and it's somewhere, I don't know where. The AC is deep and quiet, the lens is absolutely clear, and the IOP is 14. So, you know, it's a normal looking eye. Here you go. That's why I'm telling you, multimodal imaging nowadays is crucially important. So an AP view and a lateral view of an X-ray is showing an intraocular foreign body in his right eye, which is here and there, while the CT scan is obviously showing the intraocular foreign body lying in his right eye.
I see the foreign body is in the right eye, down below, near the optic nerve.
Absolutely, absolutely. And the B scan, because, you know, even though I had a clear view, it was a 6, you could, you know, you could do a fundus examination. I just want to do in every case a B scan because it gives me a clue of how deep, or is it on the surface? Is it to give me a clue where it is? Because I need to plan what instrument I need to have handy before I start operating. And as I had a view of the fundus, I decided in that case to do also a CT scan where the intraocular foreign body was located. Give me a clue that there was some fibrosis around it, and also there is a little bit of subretinal fluid around it. So case number 2. This is a 68-year-old male that felt something in his left eye while hammering on metal. Now, in comparison to the previous case, he presents with a visual acuity of hand movement. When he was referred, there are sutures, 2 10-0 nylon sutures in the central of the cornea, because the antral point was the center of the cornea, so there was a full thickness corneal laceration that was sutured by the referring physician. The saddle was negative, the AC was deep, and there was a traumatic cataract. That's why the visual acuity was hand movements. Again, on multimodal imaging, the foreign body is obvious in his right eye, but as you can see, it's just touching. I mean, is not deeply embedded in comparison to the previous case. And here you see, in comparison with the previous case, B scan, that actually it gives you a clue that this foreign body, as you don't have a fundal view in that case because of the traumatic cataract, that the vitreous is clear and the foreign body is lying on the retinal surface. So that's why I recommend the multimodal imaging. Case number 3, and that is the final case. This is a 48-year-old male that again felt something in his left eye while hammering on metal. Visual acuity 20/80, so quite good. The AC is deep, the lens is clear, and there is a temporal a corneoscleral wound with mild leakage that needed to be sutured. Here you see the color fundus photo. So here you see clearly that the foreign body is in the retina. You can see that it is somewhere in the inferotemporal within the inferotemporal arcade, and it has caused quite a serious bleeding, even vitreous hemorrhage inferiorly due to gravity. Again, AP view and lateral view, the foreign body is obvious and it's quite big. And again, on CT, here you see that actually it gives you a clue that the foreign body is quite deeply embedded in the retina, in comparison with the previous case, that there was a gap between the retina and the foreign body. And again, the B scan, that actually it shows you that there is quite an encapsulation around it, and this might be quite deep embedded foreign body. So, and I will finish my keynote speaker presentation by presenting you a case that I did 2 weeks ago. This is a 20-year-old boy, which was actually quite unlucky. He was not doing anything. He was actually observing a friend who was hammering metal in a quite a distance. And, you know, bad luck is bad luck. While he was looking at his friend doing what he was doing, he felt something hitting his eye. So, you know, in a young boy, the lens will become opaque with a white cataract immediately. So even before he was referred to us, the vision is poor because of white cataract as the foreign body. As you can see, the entry wound is through the cornea. The referral surgeon has placed 2 sutures, but they were not very well placed, and there was a leak. So I repositioned those 10-0 nylon sutures. I always place my trocars, 23G trocars, and I do a paracentesis. I have a white traumatic cataract on a 20-year-old boy, so I want to preserve as much capsule as I can. So I dye the anterior capsule with vision blue to give me a clue where is the ruptured anterior capsule, because here we know that the foreign body has gone through the cornea, the anterior capsule, the lens, the posterior capsule, and has landed on the cornea. So as you can see the flap, the ruptured anterior capsule that I use to initiate my curvilinear capsulorhexis, and that gives me an advantage to perform a curvilinear capsulorhexis that very gently and meticulously I try to do. So you can see here that I'm almost done, and I finished my curvilinear capsulorhexis. Then I decide that I know that there is a posterior capsular break, so I don't want to lose any fragment in the vitreous. So I do a very gentle irrigation aspiration, because I expect this lens to be very, very soft and very fluffy. And I'm actually right, because as you can see, it is fluffy, and I try to as you can see, I managed to remove it. But if you saw, there was vitreous, so I immediately stop and I use my cutter because I don't want to pull on the vitreous strand to create any breaks on the retina. And actually, with the cutter, the 23 cutter, and with IA, I very gently managed to remove any remnants of the lens material without anything falling behind into the vitreous cavity. But you know, you need to be patient, you need to be gentle, and you need to take your time. It will not happen, you know, in a glance so you need to be gentle. And as you can see here, I show this because now I have removed the lens, the capsule is clear, and then I can move on with my vitrectomy. You can see the foreign body is here, and as it was hot, it has created a white burn on the retina. I start my core vitrectomy, but it is a 20-year-old boy, so I know that there is no PVD. I stay in the vitreous with Kenalog, and here it starts my saga. The saga is that I cannot really do a PVD. The vitreous is very, very strongly attached. So after several tries, I say that I will move on to the surgery. So I create 3 rows of laser around the foreign body before I remove it. So to be sure and safe that the retina is well supported by the laser, and with a 23G peak, I gently touch the foreign body and gently dislodge it from the retina surface, that you can see very clearly that I do successfully. And once I do that, I use a 23G forceps to cut the foreign body, and then without any sclerectomy, but by using the posterior capsular rupture that has happened from the foreign body, I do this special maneuver, and I gently, very gently lift and very gently put the foreign body on the iris and the anterior capsule that it was left during my curvilinear capsulorhexis. As you can see here, it needs a little bit of patience to do this manipulation through the 23 gauge trocar, but I finally managed to leave it very gently there, and then I remove my 10-0 nylon suture. I put a little bit of viscoelastic to make sure that it will not fall behind the vitreous cavity, and very gently and securely I remove it from the eye. And then let me pause here. As everything has gone well so far, and I have quite a support from the anterior capsule, I decide to put a 3-piece intraocular lens in the sulcus. However, I will have a little bit of adventure. That's why I will show you this, and it shows that in a trauma, and in any case, you have to have collateral thinking and plan B. So as the lens is inserted, the 3-piece intraocular lens is inserted in the eye, and you know, I aim for the leading haptic to go behind the iris and on top of the anterior capsule, and I manage okay, and I try to do it gently. Here, suddenly, the lens opens, and actually, I have the leading haptic behind the anterior capsule and into the vitreous cavity. So, you know, I am a little bit of a difficult situation, and what I decide to do is go behind with my cutter and use I don't know how this came in my mind at that point, but it came. It found to be quite useful, and I use the opening of the cutter without doing any cutting to engage the haptic and lift it from the posterior segment or above the iris, and then with my mushroom to very gently finally place it under the iris and behind and on top of the anterior capsule, as you will see here. And to take a deep breath, do my prayers, and then to gently push the trailing haptic again behind the iris. And as you can see here, it has gone on top of the anterior capsule, and the lens is very secure with an excellent outcome. You can see here my curvilinear axis, and that is the end of the case by suturing the sclerotomies and checking that the tone is good. And I saw the young boy yesterday. It is now 3 weeks postoperatively, visual acuity 20/60, retina is attached, and so far so good. I would like to thank you for your kind attention, and once again to thank Hudson for his honor to be today your keynote speaker. Thank you.
Congratulations, Emmanouil. All cases were the best, and especially this last one. You know, we gotta be very slow, otherwise we could miss the point and put the IOL right on the posterior pole, and you were so accurate and so slow and careful. Then the lens was so centered. We usually wait a bit after some time to put the lens, but you felt so secure by doing that during the surgery, and that worked perfectly. Thanks for all cases, and I would like to say hello to Jorge Rocha. Jorge Rocha, how are you? These pretty good cases from Emmanouil.
Hello, everyone.
Yeah.
Hi, George.
Hi, Noti. Good to see you. Hi, everyone.
Yes.
Did you? What do you think about this last case where he put the IOL right on the anterior capsule? And you know, the trauma was pretty interesting. He removed the foreign body through the cornea, and then he sutured. And I think that if the foreign body was straight, and we could probably have removed it from the sclerotomy, but not in this case. I think it was quite irregular, and you made a very cool construction of the corneal wound. What do you think, Jorge Rocha?
I used to use the 3-piece lens for this case of surgery. It's worked well. I have only one problem in the long run. In a patient that I took out the metal foreign body from the vitreous base and implant a 3-piece lens. They have the syndrome of glaucoma, uveitis, and hemorrhage, and I have to take again this lens to solve this. But it's a very good approach. Beautiful case.
Thanks. Any comment from the panel? Anybody would like to comment? Mohammed, how are you? And welcome, Taufik, for your first time as well in Retinawesome.
Yeah.
Welcome.
This is the first time for me. Yes.
It was good to see you in Saudi Arabia and participate with you in those events. It is great. And
Me too.
I know that you've been to Jordan after that event as well. You've been traveling.
And now I'm in Morocco.
So what do you think of Emmanouil's case?
It's a great case, but the way of three-piece implantation is very good, and also the technique of catching the haptic by the cutter, it's very cool, and I think this is one of the points that I catch it from the videos.
All right then, Marcelo, good morning. Good morning. We are close here, Bolivia in Brazil. You are just 1 hour behind us, and good. You had a busy Instagram, media there, very busy. Thanks for sharing the Retinawesome events. And would like to comment on the Emmanouil's cases.
Yeah, thank you, Hudson. Yes, well, it's my pleasure. Well, I want to ask if you have any experience fixating the intraocular lenses three-piece in these cases. Sometimes we don't have the adequate support, so I want to know what's your experience with that, Emmanouil.
Hi, Marcelo. How are you? So if I understood correct, the question is what I will do if there is no capsular support.
Right.
Yeah. So this to me it depends according to the patient age. So if I have a patient that it is above 75, I usually put an ACIOL and that's the end of it. However, if the patient is younger than 75, then I will consider, a cannavale lens. However, I'm not very experienced with the scleral fixated IOLs, so I refer to physicians that they usually do it.
Thank you, Manuel.
Thank you.
And so I would like to call Natarajan. Are you ready with your case?
Yeah, I'm ready.
Would you like to go now?
Yes, I'll go. I will share my screen.
So Natarajan, the meeting in AIOC was pretty cool. I've got some pictures from yourself.
We had the highest number of delegates so far this was the 80th year of All India Ophthalmic Society. We had about 6,500 ophthalmologists attending and around 2,000 associate delegates and trade. And it was one of the biggest convention center which India has made in Mumbai now. So very good. So next year, hope to see you all in India. The conference is going to be in Cochin. We call the God's own country. So again, I'm happy. Maybe apart from Hudson, I've attended all the 16 Retinawesome. Thanks, Hudson, for having me all the time. And every time it's a good homework to find out which case to present. So I have a amniotic membrane graft for recurrent macular hole. The first surgery also was done by me. This was a 63-year-old presented with the metaformopsia and dark spot in the central field, and then came with a 3 by 3 meter vision. Did a vitrectomy, but again had a recurrent macular hole, the OCT shows. And then my colleague, Dr. Anupam Deshpande, did the cataract. So usually I don't do the cataract. My anterior-segment surgeon does the phaco with the intraocular lens, and I tell them, you finish and go, then I will do the rest. So I do the 3-port pars plana vitrectomy. And here it's already a vitrectomized, right? So it's only a revision vitrectomy. I'll just show you. So they generally, any of the combined surgery, whether it's a corneal surgery with the temporary keratoprosthesis, we have a cornea surgeon who will come. And for cataract, we have this Dr. Anupam and Dr. Kavita, one of them will do it. And then in this, I have this technical difficulty of using the trocar cannula where I have problem in getting the amniotic membrane into the eye. So maybe I will ask my doubts after I complete the presentation. So just the phaco is being completed, intraocular lens being put. The patient is just a week old now. So we did a thanks to Aishwarya, she did the post-op OCT, which I will be showing after the. So after the corneal surgeon, the cataract surgeon gets out, after the corneal hydration, and then I take over and proceed with the 3-port trocar cannula. This is a 25 gauge. I always do go with the bevel so that the wounds are quite well sealed when I do the fluid exchange. But here I had to extend I remove the 25 gauge port and then make a small incision and then enter into for putting the graft. Every time it was getting stuck in the trocar. So I'll actually remove the part of the opposite capsule so that there's no need to do in the future when the thing opens. You can see the recurrent macular hole, and I'll try to stain with the brilliant blue. I actually do it under the fluid exchange, and I use the Zeiss 3D RTO. No financial interest, but it's excellent for so that everybody watches in the OT what I'm doing. So here I can complete the whatever little basic session required. And then I try to do an endo drainage to see whether the hole will get reduced in size. So I'm doing the final part of the endo drainage. So nothing happens to the hole. So now I do the fluid, the brilliant blue under the air.
Nice image, Natarajan. What equipment are you using? The image is great.
This is the 3D RTO. The 3D by the RTO, the Zeiss one. So the system is excellent, and it has got a built-in recording system from the Zeiss. So you can see there's no ILM left with the first surgery. It was done well. And I still try to see whether any remnant of the ILM is left, but nothing is there. I try some small superficial hemorrhages happen. And this I'm using the flexi loop to just check whether any remnant of the ILM is there, but actually nothing is seen. So I also try again using the forceps to see whether any membrane is left behind. The idea was in case if there's some recurrent hemorrhages, membranes, I thought we should remove it, but nothing, there's absolutely nothing. So you have to be careful not to produce any iatrogenic plaque unnecessarily. So here I just see that part. So now I again do a fluid exchange. I actually try taking the amniotic membrane through the trocar. You'll see that it will get stuck in the trocar. So is there any technique, Ashray and Hudson, where through using the taking the amniotic membrane? I tried it through the fluid or through the air. Both it didn't work. So I had to remove the trocar, enlarge the sclerotomy, and then I took the amniotic membrane. You want to say something, Ashray?
Sir, what you have described is perfectly fine, sir, because amniotic membrane is slightly slippy membrane.
Right.
It doesn't go through the 25 gauge port. So we have to make a slightly smaller, like 20 gauge sclerotomy. In fact, the inner lip of the sclera is what will obstruct the amniotic membrane. So we have to just extend it. I think you will show it. Once we extend it, it goes smoothly.
Exactly. So, finally. See, now I try to take this. Every time it gets stuck there. So I tried once, twice, and then see nothing comes there in the forceps. So I left it. So finally I removed the port, used the 20 gauge MBR blade, and then I also opened the connector small.
Yes, don't you get any turbulence from the fluid moving the membrane around?
Yeah, that's right. So that's the reason I do it under air. I tried that. So the fluid also is not working. So now again, I'll remove the port, then I use the MBR blade to enlarge it and then take the, I make sure there's no...
The air sort of push it down towards the
Yes.
hole.
That's right. So I'm again, you used fluid just to check whether anywhere else. So now finally I take it after enlarging with the MVR blade and then put the, so even in the forceps it gets stuck. So again, I take little fluid and then wow, and then I do the fluid air exchange. So this is a little air, fluid there. But you can see the whole thing is moving under fluid.
Dr. Nora is asking here, why not to use serrated forceps?
We should use serrated forceps? No, what is the question, Hudson?
She's asking if you use
No, I actually use the end gripping forceps. So I didn't use the serrated. So now a little fluid was there. So the membrane was moving around. So now I use the fluid air exchange, make sure it doesn't move, and then put the graft on the way. And then I close it with the, so if you take a long time, you see that condensation happens on the back surface of the lens. So I have a trick. I put viscoelastic if this proceeds, because you will not be able to see the macula well. But that's because of the long time you took under the air. So you can use the viscoelastic on the posterior surface of the lens.
You know something interesting? You see those bubbles posterior to the IOL. I usually go with a back flush cannula, very gentle, and just touch and they disappear, because oftentimes they can, you know, hey, make your vision, you're a little hazy. So I usually go there and just remove them.
Actually, you can actually do the, so this is the post-op, it's about 10 days post-op with 50% gap hole. You can see the hole closed, and the vision with partly gap, the vision has also improved to 6 meters now. Patient is happy. Hope the patient will improve.
Thanks. This is innovating. And Dr. Miguel Vasquez is asking, would you rather use, because it worked well with the air fluid exchange, but would you rather use or have used before carbon liquids to make the graft more stable on the macular hole area?
What liquids? The PFCL?
Yeah, PFC.
Oh, no, I didn't. Somehow I didn't, maybe it's a good idea to keep the PFCL and then push the membrane below the PFCL. I think, no, I didn't try. Somehow I was struggling with under the air only.
Okay, Natarajan, and for the stability of the graft, so you make an air fluid exchange, but you keep the pressure low. You cannot, you know, don't put the pressure very high, otherwise it could cause any turbulence. Do you have any tips on that?
So one is, I think, you do the fluid air exchange partly, and then when you keep the membrane, it may be moving little, then make the drainage near the nasal of the disc, so that even if it moves, you can push it with the retinal brush and bring it back to the macular hole. So, and dry as much as possible. And then even if the condensation happens, there's no problem. And then put the patient immediately on prone position. And I tell them for a few days so that the membrane is stuck already.
Oh, all right. Great case indeed. And if anybody wants
good homework for me to look for the next case for a next Retinawesome. So I'm happy. So I want to make a list that I don't repeat the case again.
Natarajan, great case. I love your technique, but just some comments. You never aspirate from the hole just because sometimes I can touch the RPE and cause more damage. In Brazil right now, we can't do this technique because we don't have more amniotic membrane available. But if I see a huge hole like this, maybe I'll try to retina graft. And but your technique is great. One thing, how you know what's the best position of the amniotic membrane? I mean, what side? Because some people say that has the best one to
I know, I really don't know, but in this case actually it turned. So I really don't know which side is the good. So and then I thought, when I asked the corneal surgeon when they use on the surface, they say there doesn't matter, but I'm not sure about the macula.
And the last thing, it's hard sometimes to have a good visualization under the air. And maybe if you just turn off the infusion and the turbulence will not be so bad, then we have the trocar valve, and then maybe you can handle this with fluid. That's maybe the visualization is better. But if you have a good visualization with air, it's good too.
Yes, and I think Dr. Nora is asking whether it be use a small. I think exactly. I tried in the beginning, then I thought if I take small, I'll miss it, so I made it bigger. You're right. I think, fortunately, the patient is happy right now because the graft is totally closing the hole, and it's not moving. I hope it doesn't move. So there's no floater the patient is seeing right now. Thank you, Dr. Nora.
Hudson, can I ask a question to, or put a comment to Natty?
Yes.
Yes, Natty, hi, how are you doing? This is very beautiful.
Yes.
Just a few things I've learned along the line. One is to stain the membrane itself with blue dye outside.
Oh,
so
okay.
Just put a drop of blue dye. It makes it really obvious under air. So I found that helpful. The other one is to use 2 forceps and the chandelier, because as you showed beautifully, it gets stuck to the instruments.
That's right.
Yes. Third, I love the under air because then you don't need to use PFCL. So I think it's a clever idea.
Thank you. I think
thank you so much.
Great case. And before we call Dr. Ahmed Salam, before we call Dr. Nora Amasuri would like to make any comment. I know you made very great questions, and if you would like to make any comments on our surgeries, feel free to do so. Dr. Nora, welcome to be here with us.
Dr. Nora
is not yet, no problem. Ahmed, so thanks for accepting to participate. We watched many lectures. You and Tarajan, I think you did the best lectures in that meeting there. So many lectures, one after the other, and Athanasius as well. So I was sitting there, and Tarajan was going again, and you as well. So honored we are to have you.
I love, that's why. No, I want to just tell her for a lighter note. When I was small, I believe till 2.5 years, I didn't talk. So my father made all efforts me to talk. Now somebody has to tell me to stop. So Hudson, you can tell me to stop.
Yeah,
and I love talking, and I love friends, and I love teaching and I learn.
So Ahmed, I will share your case without the sound. So that you...
Yeah, thank you so much. I had problem with the computer that I've partially sorted. So thank you so much, Hudson. Again, delighted to be here, interact with friends. And this is a lovely series of videos. Thank you so much.
Just a moment.
Yeah. So I can introduce the case until Dr. Hudson gets us ready. This is an immunosuppressed patient who had acute myeloid leukemia and bone marrow transplant, then came to us with decreased vision.
Yeah, I the video.
And the patient, I'll show you the pictures when it comes, but initially the patient was just complaining of decreased vision as well as pain in the eye. Maybe until Hudson sets up, I have actually a comment about Dr. Mavrikakis' video, which I really love. Two comments. One comment, sometimes when, especially young patients, when the hyaloid is so adherent, I find a retina pick under high magnification very useful to get the hyaloid up. I mean, you still can try, and it can be difficult in young patients, but the reason I find is that the vitreous is multi-layered, and with the pick, you're able to perforate under the very innermost layer and pick all that up. So I find high magnification in a pick sometimes very helpful for that. And the other thing is that anti-chamber IOL, as Dr. Mavrikakis mentioned, is actually a very good option in all patients. Unfortunately, it has very bad reputation, but it's actually a false reputation. And I'll share with the participants a video that we put for the Academy website that has everything about the nuances of the
just let me
technique.
know. Should I start now?
Yes, actually, I'm ready. Thank you so much. Yeah, so this patient comes with decreased vision and eye pain. As I said, she had acute myeloid leukemia and bone marrow transplant about a month afterwards. The right eye, all very good, 20/20 vision, pseudophakic, doing fantastic. The left eye, hypotony, KPs, +1 cells, and +1 vitreous haze. And in the retina, we can see a retinal detachment, choroidal detachment. And then this whitish area, the pigments you see on the retina is just from the KPs. And that's her OCT with very subtle fluid. And a whitish area there, which we're thinking, is this a healed retinitis given the whole situation of the patient? So now we give the patient prednisone drops, and we're still not sure really what's happening. She comes back, inflammation is better, but there's more detachment. And the question is this an exudative or rhegmatogenous detachment? Because it was getting worse, we thought this is probably rhegmatogenous detachment, but hard to tell. So trocars are difficult. We took an aqueous tap for viral PCR and toxoplasma. And when you have hypotony and choroidal detachment, best to go towards the pars plana. Now we start cutting and we find really here that there's a tear, and I'll show you the scleren as it comes. Now you need to be careful, of course, the retina is detached. I'm sorry for the bird's sound. And the choroidal detachment, and we're just removing the vitreous, and we'll start looking for more breaks later on. Here is the money shot where you see scleren at the edge of the healing retinitis. So that's the story, a retinitis, a break. And then we couldn't find any other break. So here it's an upper break. So I did a drainage retinotomy, left the choroid alone because we need just a small amount of gas fill here. So there's no need to drain the choroid. And then laser around the drainage retinotomy and the break area. One day it's about 70% gas fill using 30% SF6, and this here 1 week after the surgery. So I think and then the aqueous PCR came back with CMV, and valganciclovir induction was started. So a few points to learn from this case. First, I mean, the story is, as I said, CMV retinitis leading to a tear and a retinal detachment. One is very important is the differential diagnosis of exudative versus rhegmatogenous retinal detachment. And it can be difficult because choroidal detachment can happen in either. And also a small number of patients preoperatively, you may not find a break. So about 2% of patients to 5% may have a choroidal detachment and a rhegmatogenous detachment. And about a same number may have no break initially during preoperative examination. But then clues are, what's the setting we're dealing with? The second clue is whether if there's an inflammation component, if it gets better, but the retinal detachment gets worse. Shifting fluid is also a clue because that makes you think of exudative detachment. When you have hypotony and choroidal detachment, then putting the trocars can be tricky. Here, I didn't want to inflate the eye with BSS before putting the trocars because I didn't want to mess up with the aqueous because I wanted to get a sample from the aqueous for the viral PCR. So always remember, in these cases, you don't go towards the vitreous, but you go anteriorly as if you're going to go into the lens, especially in pseudophakic patients. Choroidal detachment, I think if that was an inferior break detachment, I would have drained it. But here we don't need a bigger gas fill. So thinking about that, I just left the choroidal detachment alone. And then the last point is the differential diagnosis of retinitis in immunosuppressed patients. Thank you so much.
Thanks, Hamed. I hope you did not miss any part of the, yeah, I think it was here when you showed the retinal detachment.
Yes, so here we saw the scleren, and usually in most patients who had retinitis, the break is at the edge of the healing retinitis area. And that goes as well with recurrent detachment. When you have recurrent detachment after laser, for example, or cryo, usually it's a necrosis at the edge of the laser or the cryo. That's the money shot, yes.
It's not easy to see these tiny little breaks at the retinal periphery. Do you have any special technique to make them better visualized? Or
yes, I do. So first is anticipation. A more common scenario is a recurrent detachment. There's no PVR, but a patient who had laser or cryo. Usually the break is at the edge of the laser.
And how do you do this indentation without, what do you use to do the indentation here? See, I'm doing.
Yeah, so I'm eliminating from inside and I'm using a depressor, a scale depressor from outside, and I'm just playing with it to show the Schlieren more. So I think anticipation and then also looking for the Schlieren. Sometimes we have a case 3, which I hope to show maybe in a coming Retinawesome, is we did an OCT and we re-looked at how the fluid configuration was. And we found that fluid configuration looks very much coming from that area. So we knew that the break is in this area. Then you have the other options of putting PFCL to try to push the fluid peripherally, so the break would pout. And you have another option of putting subretinal blue dye to look for a color Schlieren. And then you have the final option is to think, okay, well, the break must be in this area, so let's just laser all this area or dry to dry. So these are all my options.
Great, really great. And would like to comment, Matarajan, on Dr. Salam case?
I think it's a wonderful case, and I think so. One second, I think my battery is drained.
Ahmed, it seems that something is on your camera. Something is blurring your visibility.
Oh yeah, sorry for that. I don't know what happened.
Oh yeah, it's a plastic. Yeah, okay.
Yes.
Natarajan.
I think it's a wonderful case. Really, I think only say it's a remarkable result. Wonderful. Great, Ahmed.
Oh, thank you so much. I think I can see a question here from Dr. Al-Mansouri. Yes, the patient was pseudophakic. The pupil was small. We used an illusion ring, but the patient was pseudophakic. And I think in this scenario where you have choroidal detachment and the patient is phakic, you may want to be thinking of removing the lens to be able to put the trocars confidently.
All right, then. And anybody would like to ask any more questions? This is, we've got to be very careful in diagnosing, and especially during the vitrectomy, to know the right time to go on doing the, because you have two components, the exudative and the retinosals, and then we were able to find those small breaks. And if we don't find them at all, if they are too peripheral, oftentimes I like to do some barrier laser so that we keep the retina protected. But you were very, good on that.
May I have a question? Quick question.
Sure.
Ahmed, thank you very much.
Hi.
Great case. I learn with you every time.
Oh, thank you. You're very kind.
Very challenging case. But my question is, do you consider to place a circle band, a circle buckle on this case, and use oral steroid before surgery for retina choroidal detachment to try to get better and before the surgery?
George, thanks. I think these are great questions. So first, let me answer the oral steroids first. We may, if you're thinking it's an exudative detachment and not a rhegmatogenous detachment.
Your image is...
yeah, I'm sorry, I don't know why this happens. I apologize.
I think it's probably reflects from the lights.
Yes. So it's better now, I think.
Oh yeah, it's better.
Yes, we may, but in this patient, we decided not, because the patient is immunosuppressed. And now we're thinking this is okay. it goes the story that we made before the surgery, then we're dealing with an infectious retinitis. So that's why we did not do any steroids. But I think in another context, yes, if we think this is exudative versus rheumatogenic, especially if there's inflammation, you may use systemic steroids to try to prove or disprove this. The second point about a buckle, I think a buckle is a great idea, especially if there's extensive areas of retinitis, then you may think actually the retina is very friable, and I think it's a good idea. Here was only a localized area. But I think the message is usually, yes, it's the break is at this area, usually at the edge.
All right. Thank you again.
Quick questions, Hudson. I have Ahmed, hello.
Hi, how are you doing?
Hi, Dean. My question is about the choroidal detachment. If you, I love your case, but above a choroidal detachment and hemorrhage choroidal detachment, which technique for draining did you use?
Thanks. So so in this case, I decided not to drain. The reason is the break was up and I just need a small amount of gas. So I decided to leave the choroid again. As much as I can, I like doing like try not to do any steps I don't need. So I just left it. But if the break was an inferior, was inferiorly and I needed a better gas fill, I would drain it with a trocar. So what I would do is I will see the largest point, usually it's about 7 millimeters from the limbus, and then I would put a trocar, preferably 23 trocar there, and then vent it out. And that usually works well without opening the conjunctiva and cutting the sclera.
Thank you. Thank you.
Yes. Thank you.
Mohammed Tawfiq, I know
Hi.
you have a pretty good case. I just recently, I think this week, I watched one of your ILMPOs in Instagram. Very cool.
Yeah,
You got
thanks.
good images. You can go ahead and present
Yes,
your case.
we
I
are.
think you are co-host already.
Just a quick comment on this case, sir.
Sure, go ahead, Ashraf.
Excellent case, sir. Sir, I had a case with CMV retina. Like a patient had HIV, and he came very similarly with bullous RD. And when you see a very bullous RD, we know that based on Linkoff's rule, the break can be in the superior quadrant. So we were a bit skeptical about how to go about the case. So what we did was pneumatic retinopexy. Once we injected the gas that settled down the fluid, then we just lasered the break, and patient was doing well. So that is another approach where we can take a couple of weeks to manage whether if we can manage with pneumatic retinopexy. And pivot trial has already shown from the Canada group, Dr. Rajiv Mani and all, it shows excellent results, and especially in these cases works really well. So that can be another option.
Yeah, I think it's a good point. And I think people think that every uveitis case needs to, uveitis-related retinal detachment needs to be operated with oil, but I don't think this is a must. I think it depends on the case itself, how much retinitis is there, how much scarring is there. And I agree, less is more. Thank you so much.
Sorry for any sound disturbing me, because I am already now in the conference room for Morocco Retina Society. So I just take a place for joining the Retinawesome. Thank Dr. Hudson for having me. I will present the temporal flap for myopic macular hole. This is a regular case of regular case of macular hole. This is my technique to create the temporal flap. Make a snap and try as much as I can to create one single flap. When I succeed to create this flap, I just lift it very slowly, preventing this flap to be cutted, and then put it over the macular hole. Just a small flap, just covering the hole. And as simple as it. I never use anything, just a fluid Eric's exchange, and leave the patient on air or SF6. Recently, I leave it in air. First, I was living in SF6, but I need to present. This is the pre-op and this is the post-op. This is the case that I need to present. Sorry. Wow. Well, why is this not playing the case? The case is not playing. Let me check again for what is the problem.
And this is after the air fluid exchange, but before you injected the brilliant blue. You actually you use brilliant blue or use anything else?
Yes, it's a brilliant blue. Just it. But I will not see the I will not present the video of the case, because the problem here in this case not a video. The video is a classic like the first one, but the problem here is the post-operative image. You see the post-operative image here. The post-operative, the air is gone, but the flap is there without any closure of the hole. So the question for the audience and the panelists: what shall we do in these situations? If we have this macular hole surgery, temporal flap, classic surgery, and after air is gone, I see the flap is crossing the hole without closure. I need the answer.
Actually, I will set the patient for another operation, because you know, there is this bridge over the hole, but it's still open. So I think the best thing would be to carry on another vitrectomy in this case, and maybe subretinal BSS to detach the edges of the hole around. And I learned this technique from Dr. David Chow, and he has pretty good cases. And also these cystic changes, they would settle down after you lift the edges with the BSS and make the hole with the fluid exchange. And I think that's going to be, that will close after another procedure.
Anyone have another idea?
Sir,
Well,
can I-
probably I would.
From the surgery we have now, how many days this OCT?
10 days after surgery, after the ear is going up.
It's 30 days?
10 days.
10 days. I would wait more. What you have seen is just the internal limited membrane that you just cover the hole, and the cicatrization process is going on. And then I'm just waiting for 30 days and recheck with the OCT. I have a case like this, and they continuous close. Take a while, sometime more than 30 days, but maybe. And after that, we think the reoperate. But right now, 10 days, just wait. Maybe put more gas to push the hole, but not new operation in 10 days.
Yeah, I totally agree with George. I would do exactly the same weight, or maybe put gas. I don't have any experience using air, but I would rather wait, or maybe put gas, and maybe put gas if it doesn't close with waiting.
So do you guys think, sorry, Sasamoto, George, do you think that these cysts, if they resolve and they, you know, they dry, it's likely that the hole closes after we don't have any more cysts? Do you think it's gonna, just waiting, it's gonna close?
Yeah, I just think that's maybe gonna close. This cyst is natural in macular hole. It's not something pathological. Sometimes this is positive biomarkers that is not an old macular hole, this cyst. And just waiting, we are in the middle of the cicatrization process. And then maybe we can get everything's done in 30 days or more. I just add more gas, SF6, it's enough, and put face down position for 1 or 2 days. But definitely the cyst is not a problem.
Okay, Marcelo?
Well, my situation is different. I'm living in La Paz, in a high altitude city, 20,000 feet. And the thing is that for me, macular holes it doesn't work with air or SF6. I don't know, it's a problem of resistance. I use always C3 F8 for these macular holes. Usually do citrus F8, but in this situation, I will wait 3 months probably, and then put citrus F8, or using some relaxing. If the macular hole is big, I sometimes treat it like a traumatic macular hole, using some relaxing incisions around the macular hole. That's my experience.
May I ask a question to Marcelo? Marcelo, I'm very curious how the gas, you handle gas in high altitude, how the behavior of the gas is totally different from sea level, or what you do?
Yes, we found that it's different in some ways. For example, a C3F8 gas intraocular putting in the eye, probably it lasts more than 1 month, sometimes 2 months, and that's the curious thing here in high altitude cities.
Thank you. Good to know.
Let's see what's happening for me in this case. I will show that I just do follow-up. I never do the follow-up for 1 month, and this is what the post 1 month follow-up without any intervention. The flap is closed, the hole is closed, the vision is improved, and as you can see here, the edge of the flap is there, and the constructions of the outer retinal layer is going very, very well. So my thought about the whole surgery, is it a peeling surgery or a covering, like scaffold surgery, to have a scaffold to the edges to scraping like this? And what is the rule of air? What is the rule of gas? If we just doing the scaffold over the hole and leave it, and the hole is closing together. I don't know the message from this case.
I agree with you, Taufik. Because of that, I just use 1-2 days face down position just to make sure the flap that you left over the hole is in right position. I don't use more than that, because it's not because of the gas. But another point of the gas maybe has a massage of the hole, and we have more inflammation that makes the cells, the glial cells, to move over the scaffold of the internal limitant membrane. And then just because with the gas, we massage all this area, but not because the gas will make more feasible to close the hole. But you are right.
Yes.
Yeah, great thoughts. And I think I was too fast. I rushed a little bit. I should have waited a month. And congratulations for the case. The OCT looked so pretty good.
Dr. Ahmed yesterday posted in a retina group that we have to be very careful and very how do you say,
less is more.
Simple. And then
less is more. Yes, less is more. This is a gold.
Good advice. Good tip.
Yes, I learned it the hard way.
Thanks, Mohammed.
That's a great case, Mohammed.
Brilliant case. Marcelo, you are ready for your case? Marcelo Murilo Sassamoto. And I don't hear you. Yeah, okay.
Okay.
How is COVID in Bolivia now? It's settling down. It's better.
It's settling down, Hudson. There are not much cases. let me.
I love the question from Jorge Rocha about, because Bolivia is so high, the country, and usually the soccer players, it's difficult for them to play because of the air rarefaction, so you don't breathe much. And then some people go to Bolivia before those competitions, those games. They go there a week ahead of time, or maybe a month, to train, to get used to the environment.
Well, it's only in La Paz. There are 3 cities: La Paz, Oruro, and Potosí. The rest of the 6 cities in Bolivia are like Brazil, curiously. Okay, can you see my presentation?
Yeah, it's pretty good, yeah.
Okay, well, this is a surgical approach of retina manifestation. I have no financial disclosure. I'm going to present the case number 1. It's a 60-year-old female. Patient intubated for more than 30 days, treated in other hospital for 3 months after being extubated. Chief complaints: sudden decrease in vision and eye pain. Visual acuity, left eye, light perception, and geography with media opacities. In left eye, cataract, vitritis. We found cotton wool areas. In the ultrasound, the left eye apparently retinal detachment, vitreous detachment, and the visual acuity was 20/20. So I'm going to continue. So we are performing first. We tried to do a phaco, but finally we did a lensectomy. It was really hard, really a big eye also. So we're performing now putting the trocars. We have some issues with the pupillary problems. We put some De Juan retractors. As you can see, the vitreous is dense, is whitish. And one of the things in this case was to find this dust, white dust, in the retinal walls. We tried to clean it up, but it was really complicated and difficult. So some of the dust stay on the retina. As you can see, I'm moving the instrument to try to clean it, and it was really complicated. We found the holes, put some laser, finally put some silicone oil, but as you can see, this dust was remaining in the retina. The case number 2 is a 65-year-old male, a general surgeon, with supplement oxygen in intermediate therapy for 20 days. At the angiography, we found vitritis, cotton wool macular plates, and microhemorrhage suggesting ischemic change in the papillomacular area. The visual acuity was peripheral vision. You can see all the plaques in the central retina. We performed a phaco-vitrectomy also. You can see the uveitis, anterior uveitis also. We did OCT and found this thick macular. So we performed this the phaco, and then we wanted to know how was the status of the vitreous. So we performed vitrectomy. As you can find, it was really dense, not as dense as the first case, but dense. We found these plaques, central plaques. We tried to find what was it. So we performed ILM peeling and have a biopsy to see what was the problem in this eye. After that, we use also silicone oil in this case. And that was the results from the first day post-op, 1 week post-op, and again, 3 months post-op. So it was a complicated and a tough case. You can see the OCT also less thicker, but still. The case 3 is a 60-year-old male, is the same patient, the other eye, with supplement oxygen intermediate therapy for 20 days. In the angiography, we found a vitritis, cotton wool plates, and microhemorrhage also. We performed also a phaco-vitrectomy. We found a dense vitreous, but this was the good eye, so we needed to be very careful moving and performing all this procedure in our colleague. We performed the vitrectomy. As you can see, the ischemic retina was present. We put some laser around the retina, around the plates, and also use always in these 3 cases use methotrexate intravitreal, and in the BSS putting some methotrexate also. We finished the procedure also putting, okay, this is the 3-month post-op for the right eye, the last one, the good one. It was getting better. The ischemic part also improved. So these 3 cases demonstrate that COVID-19 has a high association between systemic inflammatory responses and hypercoagulation states. It is not that COVID-19 exacerbates inactive present pathologies or initiates them. That was the case in these interesting cases. In patients with COVID-19, it was hypothesized that there are 3 input mechanisms for SARS-CoV-2 to reach the retina: through the blood, through the neuron, and by contiguity. So there are several examples of vitreoretinal disorders caused by direct viral infection in patients with COVID-19, in addition to reactive pathologies such as serpiginous choroiditis and acute macular neuropathy. A group of inflammatory choroidal disease that are in the group of white spot syndromes are acute multifocal posterior flaccid pigment epitheliopathy and a PSOR, and they were documented in patients with COVID. We think that these patients probably are in this group, the general surgeon especially. SARS-CoV infection triggers choroidal inflammation, as we know, and similar to another infection agent such as Mycobacterium tuberculosis, very high in Bolivia. And finally, which is the best treatment in patients with COVID-19? Well, conventional treatments that include lasers, injection of vascular endothelial growth factor, in some cases may be necessary. Also, we have to select the cases to use corticosteroids. In most of the COVID cases were used high dose of corticosteroids. And the other suggestion is to use antithrombotic therapy, for example, heparin, after screening thrombotic markers. And finally, the methotrexate, that acts as a modulator of the inflammatory response and blocks cell proliferation, favors to reduce these aggressive inflammatory cases in COVID. So that is my presentation. Thank you, Hudson. Thank you, Retinawesome 16.
Yeah, great cases, and you have to be aware of COVID and whatever it can cause. And please, Marcelo, tell us about your experience in methotrexate. I know you are using a lot, and that works well for PVR cases, and especially for these cases that you just mentioned. Could you tell us your experience, and how do you inject and the dosing you use for those cases especially, and comparing with normal, regular PVR cases?
In these COVID cases, I try to use probably every week, 1,200 micrograms, and for at least 6 months, because for example, this doctor, as you can see in the left eye, improved in 1 week, and then in 3 months got worse. So we need to keep an eye on them all the time. That's my experience with the COVID patients. No, besides methotrexate, use always a corticosteroid, help a lot. But still fighting with this doctor. I see him in the office every 15 days nowadays, and still finding some surprises of these inflammatory problems. So it's a chronic situation.
Yeah, thanks. Welcome, Vibe, you just got in. It's good to be with you. And how is things back in India? You were probably busy with some patients, but Vibe, how are you, brother?
Lovely. Nice to see everybody and familiar faces.
Yeah, we are. Stay put here, man. So everything all right? Would like to comment. Anybody else would like to comment on Sasamoto's case? Did you get to see the last case, Vibe?
I just joined.
And Ahmed, please.
Sorry, I think these are great cases. Thank you so much for putting them together. I think it's also the other thing to think of is that patients can have infections and endogenous endophthalmitis with COVID, and sometimes in relation to COVID treatment. So that can be, you want to immunosuppress these patients, or they may get immunosuppressed for respiratory problems, but that can also be a trigger factor for endogenous endophthalmitis. And we saw that with a patient, with several patients actually. One of them was difficult to diagnose because she had panuveitis from the beginning, and then she had COVID and was put on high dose immunosuppressants. Then she developed endogenous endophthalmitis, and because of the background of panuveitis, it was very difficult to get to the bottom of it. So something to be wary about as well.
Yes, totally. Thank you, Ahmed. I take that in mind.
Thanks a lot. And Ashraya, we are honored to have you back again on the stand. So I've got your video for presentation here. Would you like me to share your video?
Sure, sir. It has audio as well. Please check if the audio is running.
Okay, so let me share it. Just a second. I like moving this bar to the side so that it doesn't cover the slide. So you just tell me when I should start.
Thank you, Dr. Hudson, for the opportunity. Mostly all my colleagues have already discussed. So the couple of few points which in the chat people were asking, I've covered it in the video. Let's see. Sir, you can play the video.
So we just started the video.
No, I think audio is not coming. You have to click on the audio, or you have to enable the audio. You have to go back and enable.
Okay, okay. A second. I think the audio is on, but has not started yet. But I think...
No, okay, sir. I'll share it from my side. I think it is easier. You can stop it.
Do you want to share it yourself?
Yeah, yes, sir. I'll
sure.
share it myself.
Okay.
Good
evening, everyone.
The audio is coming, right?
I would be talking on inverted ILM flap, free ILM flap, and conventional ILM peeling for large, full thickness macular holes. I have no financial disclosures. Large macular holes are defined by the IVTS as more than 400 microns in the narrowest horizontal dimension. Depending on the
Azrael,
series,
if you could
5 to
close
44% of the
the
large
chat.
macular holes have been reported as remaining open after primary surgery.
If you close the
The
chat
goal of
bar,
surgery in
gonna
macular
display.
holes is to restore the macular anatomy to get a reasonable good functional outcome, and a mere closure of macular hole does not always result in meaningful visual gain. This is well illustrated in this slide. The picture on the left shows the mere closure of the macular hole with retinal layers being ill-defined, resulting in a vision of 6/60. Whereas on the picture on the right shows complete restoration of the macular anatomy, showing reorganization of retinal layers, resulting in the vision of 6/9. In macular hole surgeries, most commonly vitrectomy is done for removing the anteroposterior tractional forces. ILM peeling is done to remove the tangential traction. Gas tamponade is given to prevent trans-hole fluid leakage from the vitreous cavity to generate interfacial surface tension force between the retina and the gas bubble, helping pulling off hole edges together, which gives a surface for glial cells to migrate and fill the gap. This is the conventional ILM peeling technique, which is done using the pinch and release technique for initiation of the ILM peeling. Once the ILM peeling is initiated, it is slowly extended to peel the ILM across the macular hole, making the macular hole free from ILM from all its remnants and from all the edges of the hole. And ILM is extended to around 2 disc diameters around the macular hole. And in the end, 20% gas bubble is used as gas tamponade. So this is a case where the horizontal diameter had more than 400 microns. It was about 1,200 microns, and it closed with type 1 closure, giving a visual gain of 6/9. Problems with conventional ILM peeling are many. However, it has good closure rates for holes up to 400 microns. Large macular holes more than 400 microns show low closure rates and less visual gain. Large macular holes that have ended up achieving closure after conventional ILM peeling are more prone to display in a W-shaped pattern or a flat open closure pattern corresponding to the type 2 closure. So other options are the inverted flap technique and its variations, retinal expansion technique, retinal graft, lens capsular flap transplant, autologous blood plug, amniotic membrane graft, and retinal massage. Today we'll be seeing a technique as described by the Michalewska et al. In this technique, a conventional 25 gauge vitrectomy is done after inserting the ports, and PVD is induced conventionally. And once ILM is stained under here, it gives a good staging of the retina and has a better visualization. Peeling is done after using the pinch and release technique, and all the edges from around the macular hole are peeled till the edge of the macular hole.
ILM is peeled till the edge of the macular hole around the macular hole. Unlike the conventional technique, it is not peeled across the macular hole. When sufficient ILM is peeled around the macular hole. Then the ILM flap is trimmed using a high cut rate and a low vacuum. Care is taken not to completely rip off the ILM from the edges of the macula. Once done, 20% SF6 is used as a tamponating agent. Another technique which is commonly used is a retinal massage as described by Alberto et al. Here, after the inverted flap technique, the blunt tip of the cutter is used to mobilize the edges of the macular hole in all directions. This is only to make sure that the edges of the macular hole are mobile. And once done, you can expect results similar to the cases which we are showing it now. So these are our few of our cases which had excellent anatomical and visual outcomes. And in the last 1 year, we have operated around 71 eyes using this technique with a primary success rate of 97.18% and a final closure rate of 100%, with the average visual gain of being 6/15 and the average macular hole diameter being around 800 to 950 microns in diameter. Technique was described by Morrison et al., wherein after completion of the ILM peeling, a small flap is peeled from the outer border of the completed ILM peeling and then placed over the macular hole to cover it. We had a case where a 65-year-old female came with a diminution of vision with the presenting vision of 6/18. You can see this large macular hole with a diameter of 2,297 microns at the base and a minimum diameter of 1,600 microns. In this technique, we deferred both conventional and the inverted flap and used the free flap technique. We used the conventional 25 gauge vitrectomy, and after the anterior vitrectomy, we visualized the macular hole with ERM. So after the anterior vitrectomy, PVD was induced conventionally. And once vitrectomy was completed, we removed the ERM carefully without causing more trauma or without enlarging the hole. And BBG was used to stain the ILM under air for better visualization. And after the ILM was stained, it was carefully peeled using ILM forceps. Since there was a patchy staining, we stained again with brilliant blue dye and made sure that the macula is free of ILM. By removing the fragile and thin ILM in this large macular hole case. Once the ILM was freed from the macular surface, we initiated to make a flap of ILM in the superior area of the superior, above the superior arcade. We removed a large flap and placed it over the macular hole. And care was taken not to tuck it inside the macular hole, and to keep it stable over the macular hole, we used a drop of visco so that it doesn't get displaced during fluid air exchange. Then after fluid air exchange, 20% gas was used and ports were closed. This was at post-op 1 month with macular hole having type 1 closure with vision improving to 6/24. At the end of 3 months, we were quite surprised with the visual outcome of 6/9. Large macular holes are surgical challenges with poorer anatomical and visual prognosis. Hence, inverted flap and free flap techniques are better surgical alternatives that may improve the chance of a better anatomical outcome. Thank you.
Congratulations, Ashraya.
Yeah, excellent presentation. Yeah, sorry.
Go ahead, Natarasha.
No, I think a lot of take-home points, and I think really difficult cases. Wonderful, Ashraya.
Thank you.
Yeah, all right. Vibehab, you are ready to comment on Ashraya's case?
Yes, very nicely done, Ashay. I really enjoyed the cases. And my question to you is, the visco really helps. And how many drops do you actually put over the free flap to keep it in position?
So Vaibhav, thanks for an excellent question. So we shouldn't use too much of visco, because again, it can displace when we are doing a fluid air exchange, it can again displace the flap along when you're trying to suck it out. So use it as minimal. So a drop or two will be enough. So the idea is, when you remove the ILM, according to the Vogel et al. Of the 2006 article, the retina stretches by 1.28%, 1.28 times. So when the large macular holes beyond the 1400, 1500 microns don't always work with inverted flap, because the stretching has a limit. Beyond a certain point, what Natarajan sir also told, in those cases, inverted flap doesn't really help. So in those cases, a free flap or a graft will help. So that is why we have to use a visco instead of a PFCL. Someone asked, PFCL can be used. PFCL can also migrate subretinally. So that's why we use visco.
Okay, I think
Can I make a quick comment, Hudson? Ashray, that's a very nice presentation. You've put the techniques together very nicely. I really like your suggestion of just making an ILM peel of it's under 400, and then if it's over 400, then we can talk and suggest and think of other techniques. This is the message, right? Am I correct?
Correct.
And I really like this because when I was a fellow, macular hole surgery was fun, was really fantastic. You just go there, do peel, everyone is happy, and it usually closed. But then came about all these new techniques, and macular hole surgery became very elusive. Is the flap going to stay or not going to stay? Am I making the right angle for the flap? And it just became difficult. You know, before that, it was just fun. You do peel, everyone is happy. So actually, I think your scheme here is very nice, that at least for the less than 400, just keep it simple and do the nice peel. Before 400, we can talk. Oh, sorry, more than 400, we can talk.
Sure.
Yeah, cool. Natarajan, you were trying to ask a question and the sound didn't go through. And before Natarajan asks his question, I would like to comment the way I usually perform this, you know, we have to avoid the flap from coming out of the way. And I love using PFC, perfluorocarbon liquids, for some patients that I combined with retinal detachments. And then the perfluorocarbon makes stabilization of the flap. It doesn't come out. But then I realized that if I do an air fluid exchange and I put the pressure low, if I keep doing pretty much what you did, and by peeling the ILM like an onion-shaped peel, and then I leave for the aim of doing the inverted flap technique, I keep the ILM attached and I just stuff it in the hole for large macular holes. It doesn't come out. And after that, I do a very slow air fluid exchange and the flap stays there. Because the brilliant blue stains very well the ILM, the next day with the indirect, I can see whether the flap is still there. And most of the time it's still there and it's stained with a brilliant blue. So I like, you know, those experiences. I was trying to do these flaps and they just came out with the air fluid exchange and turbulence. And so I have two weapons to counteract this action. Could be the perfluorocarbon liquid or the air fluid exchange, but keeping the edge for the inverted flap technique attached to the rest of the retina so that it wouldn't come out. So your technique is pretty good. And I love the way you trim the ILM around the hole with the cutter. By doing with the cutter, don't you think you could get the whole thing inside the cutter?
So I mentioned in the video, sir, you have to use a very low suction. My suction is at 50. So why we have to do that is if you have a very large flap, because while doing fluid air exchange, because of the currents, it can get ripped off from the macular surface. Then you will have to do a free flap. So keeping that flap to the minimum, actually in the post-operative OCT, you will like today was my OR day. Morning I did my macular roll case. By evening it was closed. So if you keep the flap to a very big large size, then that can itself cause outer retinal defects. That's an defect which is seen in the early part of closure of macular hole that can remain for a very longer time, because we are trying to remove the traction and we are leaving some amount of traction. So leaving a minimal ILM can help you to recruit these glial cells. As it can instead of acting like a scaffold, it will start acting like a traction. So that is why the flap height should be very less. So that is what has given us good success rates across 71 cases.
Okay, so that was the last case, and I hope you enjoyed our conversations. We will still have time to ask questions and comments. And Jorge Rocha, pretty interesting cases in the vitreoretinal surgery. I always say we always learn with each other. We have different techniques, but we are always learning something different. As you know, as Ahmed said, when I started my retinal fellowship, when I was leaving Toronto, people were starting to do macular holes in with the ILM peel. And people shake it a lot, you know, they were so afraid of doing things, and that was the what we had to do. And I remember calling Dr. Divani in Toronto. He said, "This is amazing. You just remove the ILM, and then the hole attaches, the hole closes in virtually 100% of cases." And then with time, we saw recurrences in many cases, and we had to switch techniques. So we are always learning. And I know that today with amniotic membranes, RPE grafts, and many other things, we are improving our techniques. What are your thoughts on that, Jorge Rocha?
First, I'd like to thank you and all the audience to be here. It's very nice to get together with so distinguished colleagues and learn a lot. And another stuff I love the Salam talk is when I was not too old, but at the beginning when I was resident, we just removed the hyaloid and put gas, nothing with the internal limitant membrane, and we have more than 6-7% close. Just remove the vitreous and the hyaloid, and but still have a big problem with huge holes. Have some biomarkers like time. People has with more than 1 year of the macular holes, the people avoid to operate. But nowadays, these things improve a lot, and we are operate everything and have pretty much good results. And almost all the cases have more than 9% closer, sometimes 98%. And sometimes we have to think we don't need to remove the internal limitant membrane. If you have a small road, like 200 microns, just remove the internal, the hyaloid and put gas, and don't need to, like the old times, to be 7-8 days face down position. That's terrible for old people. And sometimes with people that has a problem with face down position, can use oil. I don't like it, but sometimes we can use that and can enclose as well. But the macular hole is something so special for retina specialists. Nowadays, we are trying to understand the biomarkers and standardize the surgery and say, oh, with these biomarkers, like the size of the hole, if you have cyst or no cyst, if you have atrophy in the retina or not, and we have to define what's the best technique for which case. This is the point right now, to understand well who's gonna take the limitant membrane, who's gonna take only flap, or we have to remove all the 360 limitant membrane. How much time we need to face down position, gas, air, and everything. I think we are in the point that we need to define the good biomarkers to read technique, because nowadays each one do what they think is best, and they have more experience. But I think in more 2 or 3 years, we're gonna have better results and good biomarkers that defines which technique for which case. Thank you.
Thank you, and I would let the closing remarks to Vaibhav Sethi to thank Dr. Emmanouil for being the keynote speaker. Okay, thanks, Vaibhav.
Thank you so much, and I'm so sorry I had to miss the initial part. I'm unlucky, just like some of the people. But I think what Dr. Rocha said very well. I think we're moving toward minimally invasive macular surgery for macular holes. So the lesser done, the better it is, and especially even a lot of surgeons are using only air as tamponade, and they're getting as good results. There's no need for gas injection as well. the hole is closing in 3 or 5 days, and I think that should be the take-home message. You do what is best in your hand, but do minimal with maximum outcome.
Thanks.
I agree.
Emmanouil.
Less is better.
You were awesome, Emmanouil, with those trauma cases in the keynote lecture. And thank you again for agreeing to participate. And
my honor, my honor.
Jorge Rocha, what do you like to say?
I'm just saying that it's good to be here, but I miss a lot our friend George Mitri that just passed away yesterday. And I know if everybody knows him, was a very unique person, very friendly, and very good retina specialist and solution. And I just like to remind him this last remarkable. Thank you.
Thank you. George Mitri will be always in our thoughts. He was a pretty good surgeon and friend, especially friend. And it was so nice to be here with him in Retinawesome. And we pray for his family and all his contacts. Thank you very much again. And have a great Saturday. This lecture will be in YouTube pretty soon, this afternoon. Thank you, Emmanouil, and thanks all for participating.